As we progress in this hour, we have Ralph Clayman talking about determining the safety threshold for passage of a ureteral access sheath in clinical practice using a purpose-built forced sensor. Byron Joyner, he's going to talk about the comparison of two national surveys, 2004 and 2019, program director's perspective regarding ACGME requirement and effectiveness of training urology residents. Last but not least is Raj Pruthi from UC San Francisco, wRVUs. Do they really measure the workload and complexity of what we do? This will be followed by a live portion for discussion.
Dr. Flanagan, Dr. Bidlani, members and guests. It is an absolute pleasure and an honor for me to be able to present the material that we have from the University of California, Irvine on determining the safety threshold for the passage of an ureteral access sheath in clinical practice using a purpose-built force sensor. These are my disclosures. The ureteral access sheath is used in ureteroscopy for removal of stones, is a blessing in many respects. It shortens the operating room time, it saves money per case, and it does not induce ureteral strictures, as has been nicely shown by Preminger and colleagues literally 20 years ago. In addition, it has other benefits, including lowering the intrapelvic pressure to prevent pilovenous and pilosinus backflow, increasing the flow of irrigant, improving the active deflection of the flexible ureteroscope, and also improving the stone-free rate. However, if pushed too hard, it can also be a curse, or as Dr. Gavusi would say, if it don't go easy, it don't go at all. And in this respect, there have been important articles published by Olivier Traxler, in which among almost over 350 patients, in using only a 14 French sheath, they recorded significant injuries in 13%. In essence, a urethral tear and less than a 50% transection of the ureter. More recently, Dr. Manga and colleagues, among 83 patients in whom, again, only a 14 French sheath was used, noted a PULS-3 injury rate of 23%. So the challenge is, what is a safe deployment force for ureteral access sheath? Because right now it just depends on the touch of the surgeon, and how much force is exerted before you get a clinical injury. In order to answer this question, at the University of California, Irvine, in cooperation with our School of Engineering, we developed what you see here as a force sensor. This force sensor will record the amount of force applied to an access sheath in hundredths of a newton. We first took this into pigs to study, again, how much force does it take to split a porcine ureter. And in this study, we were able to show that if the dilator was more than 14 French or greater, at a force of 8 newtons, you began to see ureteral tears. Conversely, if the force was less than 4 newtons, we were not seeing any injury. This was then taken into a clinical study. 4 surgeons participated, and we recommended that they do not exceed 8 newtons of force. In this regard, a 16 French rather than 14 French was used as the initial access sheath to pass. And if 8 newtons was reached, it was recommended that you then downsize the sheath. At the end of each procedure, the surgeon of record reviewed the ureter in its entirety and gave it a PULS score. We had 200 patients in the study with 210 ureters. Approximately a half of them received preoperative tamsulosin for a week in an effort to relax the ureter. And approximately a fourth of them came to us with a pre-existing ureteral stent. These are the sizes of the ureteral access sheath that we used. By keeping the force at 8 newtons or less, we were able to pass a 16 French ureteral access sheath in 61% of our patients. The mean force of deployment, even for the 16 French, was 5.65, but as you can see, on occasion, the surgeon exceeded the 8 Newton limit. And indeed, we had 2 patients who had a pulse 3, both of whom the 8 Newton limit was exceeded. And we noted that a force of less than 5 newtons consistently resulted in a pulse of 0 to 1. Of note, pre-stenting resulted in an increased ability to pass the 16 French access sheath at a very low and acceptable pressure, but we could identify no benefit for tamsulosin. Is a bigger sheath better? When we reviewed this in our shop, what we found is that while the 16 French did not improve the CT absolute stone free rate, it did, however, significantly decrease the OR time. In conclusion, the ureteral access sheath with the force sensor continuously measured deployment force during passage of a ureteral access sheath in the clinical setting. Limiting the deployment force to less than 8 newtons resulted in no splitting of the urothelium. Limiting the deployment force to less than 5 newtons consistently resulted in a pulse score of only 0 to 1. And lastly, pre-stenting, but not tamsulosin, was associated with securing a larger ureteral access sheath while routinely achieving a low pulse score. Thank you.
Good afternoon. I'm Byron Joyner. I have no disclosures to report. Thank you for allowing me to present this 15-year retrospective trend survey of urology program directors' perspectives regarding ACGME requirements and effectiveness on training urology residents in the United States. Residency training in the United States has shifted over the last 20 years from process and structure and the competency-based education with the 2001 Outcome Project to milestones-driven competency with the 2011 Next Accreditation System. The Next Accreditation System consists of the triumvirate of program accreditation, institutional accreditation, and the Clinical Learning Environment Review Initiative, which in fact create more alignment with the program director's directive from the ACGME to integrate the new systems into programs. We surveyed program directors to determine the attitudes and actions they took at the different times and to identify some barriers to engaging with and implementing change. Our survey design included 26 Likert scale questions for the 2004 study and 34 Likert scale questions for the 2019 study. The latter study followed a similar design to the first, but questions were specifically tailored to address and examine the unique changes embodied in the 2011 Next Accreditation System. Each survey had an ad hoc committee that sought to review the questionnaires for content, quality, clarity, and effectiveness. Both surveys were distributed using the What You See is What You Get software program. The 2004 survey was distributed to 119 programs, while the 2019 survey was distributed to 105 programs. Likert scale questions consisted of strongly agree, neutral, disagree, and strongly disagree. The bookends were collapsed into two categories, agree and disagree, to consolidate responses. This study received IRB exemption from the University of Washington. All 8 AUA geographic regions responded with an even distribution of large, medium, and small programs. Residency programs are now larger with greater than 12 total trainees compared to the 2004 survey. In both studies, there were high response rates and high program director involvement in the iterative changes that needed to be made. In the 2019 survey, 66% of those responding were new to their roles as program directors, and nearly 70% were not responsible for implementing the change required for the Outcome Project. Program directors were, however, able to build upon the changes established by the Outcome Project using both internal and external educational opportunities, which were not available in 2004. Since then, there has been time to develop more networking and resources around educational opportunities. In comparing program director perspectives about the usefulness of the competencies versus the milestones, fewer program directors felt that the milestones were useful. 36% of the responding program directors felt that the core competencies were useful, compared to only 25% who felt that the milestones were useful. Of those 25%, program directors felt that the milestones helped them with early identification of struggling residents, and that the milestones helped with resident progression, promotion, and graduation. Of the 42% of respondents who felt that the milestones were not useful, most program directors felt that the milestones were not validated, and many felt that they lacked specific feedback to improve resident achievement. Section 6 mandates are the newest part of the next accreditation system. They align hospitals' accountability through the Clinical Learning Environment Review Initiative with programs' accountability in educating both residents and faculty about the same 6 key performance areas as you see listed here. 80% of the program directors responding were involved in educating their residents and faculty. 1/3 of the responding program directors designed their own educational curriculum, while 1/3 of program directors depended upon their sponsoring institutions to educate their faculty and residents. As you can see, there were barriers that program directors identified that led to inertia of implementing change. As part of the 2019 survey, we looked specifically at the relatively new ACGME policy regarding protected time for program directors. Interestingly enough, 17% of the program directors reported that administrative time is not protected based on salary or productivity benchmarks. Of the remaining 73% of responding program directors who were actually getting the 20% protected time, 62% of those felt that the 20% protected time required for program directors was just right. 38% felt that the protected time should be increased to either 30 or 40%. There were differences in the reported adequacy of program director protected time, with program directors from larger programs wanting more protected time. The reason I chose to do the study was to examine the concept of change management as it relates to changing the graduate medical education learning environment vis-a-vis the educational policies introduced by the ACGME. Our study has limitations, some of which are we use non-validated surveys, and we have non-standardized resident assessment tools, and haphazard methods for faculty development. In spite of these limitations, many responding program directors felt that the ACGME requirements are benefiting the future workforce of urology. In 2001, with the introduction of the Outcome Project, program directors were solely responsible for the implementation and integration of the new program requirements. For the next accreditation system, not only did the ACGME distribute the work through the Clinical Competency Committee and the Program Evaluation Committee, but they provided protected time. And by necessity, specialty societies like the Society of Academic Urologists began to provide 1, standardized education to program directors, 2, networking opportunities for them, and 3, the sharing of ideas to assist in the integration of the ACGME's new requirements into their programs. Although program directors' administrative demands have increased as a result of more ACGME requirements, it is a bit easier in 2021 with the ACGME requiring more alignment of goals between hospitals and programs and at least 20% protected time. As all the stakeholders continue to learn to work together, program directors can secure more resources to create a healthier learning environment for their residents. Thank you very much.
Thank you, Dr. Bidlani and Dr. Weiss. The objective of this study is to determine the correlation of RVUs in urology with surgical complexity and physician workload. There's increasing use of productivity-based compensation models, especially for employed positions, and we're seeing it increasingly in academic urology. The wRVU has become the currency to measure the work that we do and the complexity of what we do. In 1992, Congress reformed Medicare based on the work of Shao and a group of Harvard researchers from the late 1980s. Shao's group, with input from different specialties, developed for the HHS a resource-based relative value scale. Shao and his team sought to measure the relative value of every single one of the thousands of services provided by doctors, a job later compared to measuring, quote, the exact amount of anger in the world, close quote. For example, Shao's team deemed that a hysterectomy required 3.8 times more mental effort and 4.5 times more technical skill than a psychotherapy session. The current system includes three components: work practice expense and professional liability insurance, with final payments incorporating a geographic adjustment, as well as a conversion factor determined annually to accommodate budget constraints. As part of this work, a technical consulting group of 3 urologists nominated by the AUA and AMA were created. They looked at 405 urology CPT codes and selected what they deemed were the most important 22. They then administered telephone surveys to a national random sample of 115 urologists to rate pre, intra, and postoperative service work for these codes. For the remaining 383, work was determined in a similar fashion by surveying 28 urologists nominated by the AUA. For these surveys, each component of work was defined by the product of time in minutes and intensity, defined as a combination of technical skill, physical and mental effort and judgment. This is the original description from Shao's work and from Dr. Litwin's 1993 article, the first to address the resource-based relative value scale in urology. Relative assessments of work were made by starting with a reference service assigned as a work value of 100 units, which for urology was an outpatient diagnostic cystoscopy in a man with microscopic hematuria, then rating the work of other serves relative to this. A cross-specialty panel was formed to link all procedures onto a single common work scale, the resource-based relative value scale. The process has evolved today to a committee that may make recommendations for RVU changes. For a specialty to propose a change in a work RVU value for a CPT code, that specialty society, for example, the AUA, compiles a standardized summary of recommendation form, often based on survey data from its members, sometimes a survey of 50 or less physicians, which describes the typical patient and work involved during pre, intra, and postoperative periods. This is reviewed by the RUC panel of 30 physicians representing the AMA and specialty societies. 8 of these are surgeons and 1 from urology. This committee makes recommendations to CMS, who then updates quarterly the values. Remember, because of budget constraints, increasing the work RVU for one CPT code requires decreasing it for 1 or more other codes, making this a zero-sum game. Who gets the survey? I've never gotten the survey, don't know anybody that has, but it can be a variety of different folks in a variety of practice settings, and changes can be made based only on 30 responses. Given the fact that work RVUs are becoming a common measure of productivity and compensation, there's increased interest of whether they correlate well with measures of our workload, the work that we do. We wanted to know if they're an accurate currency. They do seem to correlate fairly well with hepatic and vascular surgery, but not so well with general surgery. But how about our specialty of urology? We examined the NISQIP database from 2012 to 2016, where we chose 56 CPT codes identified representing the spectrum of urology. Our main outcome variables are shown here: op time, length of stay, morbidity, mortality. But as a secondary objective, we also looked to see for outliers. We identified over 200,000 procedures over that 5-year period. We excluded non-elective and concurrent CPT codes that gave us 190,000. RVU values range from 4.6 for a small TURBT to 44 for a cystectomy. For the aggregate of the cases, RVUs correlated relatively well with length of stay, OR time, and morbidity, but only moderately with mortality and unplanned readmissions. We also looked to find outliers. For length of stay, you see the outlier of lap partial nephrectomy with relatively high RVUs for a median length of stay of 2 days. For op time, you see the outliers of epididymo, vasostomy, and PLND with relatively low RVUs. We'll touch on this in a moment. For morbidity, lap partial and lap ureteral reimplant had relatively high assignments. Mortality, there was nothing, probably due to low event rates for that outcome. SEEs, again, high for lap partial and lap pyeloplasty. And readmissions, relatively low for ureteral neocystotomy. Since the existing methodology is based on survey, we thought that a multivariable model would more robustly identify procedures with outlying variables. We found that RPL&D had a projected increase of 10.6 wRVUs, likely due to the median operative time of 256 minutes. Cystectomy with pelvic lymphadenectomy increase of 6.5 wRVUs. Lap ureteral reimplantation, a decrease of 6.7 wRVUs, likely due to lower morbidity. And similarly, lap partial nephrectomy, a decrease of 6.8 wRVUs due to shorter length of stay and lower morbidity. So contrary to our hypothesis, RVUs generally appear to account for physician workload by postoperative morbidity for the entire aggregate of urologic procedures. It doesn't appear to be a reflective measure of more severe complications. And we did identify some important outliers which could potentially benefit or be addressed by a more data-driven objective approach. I think an interpretation of our results are limited because of the outcome measures that we chose of length of stay, operative time, and so forth. But it does highlight, I believe, the need to incorporate objective data in an effort to improve RVU assignments. It appears that RVUs may not consistently account for the work done by a surgeon up to 30 or even 90 days postoperatively. And also it doesn't account for patient comorbidities that influence the occurrence of complications. For example, some studies have shown that in general surgery and urology, a third of readmissions are unlikely related to surgical quality, but due to patient comorbidity. The study also doesn't address issues such as quality of care or cost of care, increasingly important in value-based healthcare systems. And it needs to be consistent within urology and across surgical subspecialties. And I'm just going to show you very briefly. We analyze that across a variety of subspecialties. There's urology. And there's certainly some winners with regard to uptime and length of stay, and losers, and urology falls into that. And here's for just an example of uptime. And then with regard to outcomes and complication rates, some again winners across the board and losers as well. To conclude, the current study is the first to explore the relationship RVUs and multiple measures of surgical complexity and workload for a spectrum of urologic procedures. I believe there needs to be an objective and even formulaic process which would be welcome rather than a survey of 30 or even 50 physicians and what ends up being a zero-sum game. I just want to thank some of the collaborators that helped me with this project. I'm happy to answer any questions. Thank you.